Hi everyone, welcome back to another video. Today we'll be doing our second video of the CT series and talking about CT contrast. Previously, and possibly even right now, practices are dealing with the whole contrast shortage situation, and my own practice has tackled this issue by using other vendors' contrast. But what exactly are the differences between all these products? Let's find out. Contrast media by itself contains iodine molecules. Due to the high atomic number of 53 compared to normal tissue, the incidence of photoelectric effect is different and thus appears different compared to normal tissue. Iodine has a K peak of 33.2 kiloelectron volts, which is close to the average energies used in CT. Now, as a basic, contrast structure is based on a triiodinated benzene ring, which means there are intervals of 3 iodine atoms per molecule. But depending on the product, there may be 1 or 2 rings. The 1 rings are called monomers, while the 2 are denoted as dimers. Contrast is designed in this ring shape to provide a stable framework to bind iodine and have less toxicity on the body due to decreased protein binding with the compound. CT contrast is broadly split into 2 groups, ionic and non-ionic. The categorization depends on the side chains, or the Rs here, bound to the benzene ring. Now, reactions are broadly caused by the structure or the composition of the contrast, rather than to iodine itself. It is quite physically impossible to be allergic to iodine, as the body naturally uses it to produce thyroid hormones. With ionic contrast, one of the end chains is replaced with the salt end. When it is in solution, the compound would dissociate or split into 2 ionic parts per 3 iodine molecules. Now, due to this increased concentration of particles compared to the non-ionic contrast, ionic contrast is usually much more reactive. On the other hand, since non-ionic contrast can supply the 3 iodine atoms without dissociation, it is much safer and has vastly replaced ionic CT contrast. Roche in 2022 reported the mild to moderate reaction rates as being 12% for ionic and 3% for non-ionic contrast. If there is one thing to know about contrast, it is osmolality. Osmolality is defined as a concentration of dissolved particles of a chemical in serum. In a sense, it refers to how much a solution dissociates within blood. The higher the number of particles, the higher the osmolality. Now, unlike osmolarity, which is the number of dissolved particles in a liter of liquid, osmolality is in a kilogram of liquid, which means it is independent of the temperature and pressure. Think of it as a way that water expands when it is heated. This will decrease osmolarity, but not osmolality. Granger in 1980 suggested that osmolality is the cause of that iconic warm flush sensation, owing to large fluid movements into the vessel. As osmolality increases, so does the sensation. Ionic contrast causes a large increase in osmolality. This causes more movement of water into vessels, localized vasodilation, and increased pain at the injection sites. Osmolality of contrast is compared to that of serum, which is 300 milliosmoles per kilogram of water. CT contrasts are split into 3 levels of osmolality. The first one is high osmolality contrast media, or HOCM. These are usually 5 to 8 times the osmolality of serum. Ionic contrasts, such as gastrografin, are placed in this category. Now, there are other reasons why you can't use gastrografin intravenously, but osmolality is one of them. Low osmolality contrast media, or LOCM, is the second level. Contrary to the name, the osmolality of these contrasts are still higher than serum or blood, but way less than that of HOCMs, usually about 2 to 3 times higher. Most contrasts used nowadays in CT are within this range, and these will be your non-ionic monomers, such as Omnipaque, OptiRay, and Ultravis. The last ones are the isoosmolar contrast medias. They have same or similar osmolality to serum. The only current one that fits this description is Visipaque. This contrast is a non-ionic dimer, meaning there are 6 iodine atoms per 1 molecule. The advantages of this type of contrast is you can use less of it to get a similar enhancement to other contrast medias, but are usually more expensive and a little bit more viscous. Now, the concentration, which are these numbers on the contrast bottles, is the amount of iodine per mil of contrast. Jung et al. In 2011 suggested an interesting finding in that a concentration of 300 and 370 made no significant difference in renal cortex enhancement in all contrast phases. Now this comes as a good point to think, as lower concentrations mean lower viscosity, and Barron et al. In 2008 has suggested this as an advantage of reducing the risk of nephrotoxic effects. Alright, let's get on to the fun bits. Different manufacturers of contrast had different routes of administration. For pretty much everything non-ionic nowadays, it is good to use intravenously and intraarterially. Omnipaque is pretty much considered a universal contrast, meaning it can be used orally and even intrathecal for milligrams. However, be careful as it depends on the concentration. Omnipaque 300 can be used intrathecally, but not at 350, while other manufacturers have developed variants specifically for intrathecal use, such as the IsoView M lines. Intrathecal administration is one of the more complicated routes in CT, as a lot of contrasts are neurotoxic. The exact mechanism isn't really set, but effects can include things like chemically induced meningitis. Let's finish off by talking about contraindications to CT contrast, and why they are considered that way. Now technically the only absolute contraindication is anaphylaxis to CT contrast. However, the way departments approach this and other contraindications are different, and this video is aimed to just explain why some of the other ones are considered that way. The second factor I'm going to dive into are patients with untreated hypothyroidism. The excess levels of iodine from contrast can cause something called a Jod-Bastow phenomenon. In a sense, the normal autoregulatory effect to inhibit large amounts of thyroid hormone synthesis is affected, and this causes something called thyrotoxicosis. Symptoms of this include tachycardia and heart failure, but these generally appear weeks after contrast administration. The last thing that I want to talk about is renal impairment. For the most part, this is defined as an estimated glomerular function or an eGFR of less than 30. The main risk for patients in this range is developing contrast-induced nephropathy, which is defined as an increase in 25% or more of creatinine within 48 hours of administering contrast. This increase happens in the first 3 to 5 days, and creatinine usually returns to baseline by 2 weeks. The exact mechanism of contrast-induced nephropathy is not well known. The first suggestion is due to free radicals and the contrast osmolality itself causing renal epithelial cell damage, which in a sense is saying it's a direct damage to the kidneys. The other mechanism suggested is a renal parenchyma ischemia. Now what's interesting to note is that the renal medulla normally operates under a low blood perfusion condition, owing to a more kind of capillary artery structure. Normal oxygen pressure in blood is about 75 to 100 millimeters of mercury, but at the medulla it is around 20. Contrast is suggested to cause temporary decrease in blood supply to the kidneys and increased demand of oxygen from the renal parenchyma. These mechanisms can lead to that sort of AKI or acute kidney injury effects. So what does this all really mean? The pathways around patients with impaired renal function and previous reactions to CT contrast vary between practices, and this video is not here to give a set instruction due to such differences. However, I feel it's good to understand the differences in contrast composition and how this can affect patient experiences with contrast and care. Either way, it's been a bit of a long video. I hope you all have a good day. Thank you so much for watching.